There we go. You can all hear me okay? Okay. So the Hawkesbury General Hospital is a medium-sized rural community hospital just towards the border of Quebec, so it's within Ontario. We are a hospital under expansion. We currently have 69 beds, but shortly we will have 104. We have over 140 physicians and almost 800 employees. I'm the chief of staff at the hospital since 2013, but I've been working there since 2005. I'm a family physician by training. I still do have a private office where I take care of my practice, but I also do work in the hospital as a hospitalist, doing obstetrics, doing a little bit of emerge, basically a good old-fashioned country doc. I've also been the IT lead for the Lower Outaouais Family Health organization. Actually, we're a FIT now, so the family health team, where in 2009 we went from being completely paper to completely paperless in integrating a full EMR. Prior to my work in Hawkesbury, I was in Toronto. I was the program director for the family medicine program at the University Health Network, and I worked at Mount Sinai and the Toronto Western. So I'm going to start with a real example of how I think a scheduling software such as PedalMD can help. So we've been with PedalMD at Hawkesbury for a little while now, and in this past year, I was wandering around and got a phone call saying we have a code orange. A code orange is an external disaster. So Boston Marathon, that's a code orange. For us, it meant a school bus. So we're a small emerge. We see actually quite a bit. We see almost 50,000 patients a year, but we have 2 docs on at a time. And we got a call that a school bus was hit in the morning and that we had 25 injured children showing up in the next 15 minutes. So what did I do? I pulled out my phone and I went, holy cow, I got to find some doctors now. So I went to my PedalMD console and I said, okay, who do I have here in the hospital? And right away I started looking. We have it broken down by clinic, by OR, by endoscopy, by on-call. So I scrolled through and I found, okay, I've got an ENT guy in the OR. Called him right away. I said, hey, Barant, I need you. No problem, hold the next case. I'm with you. I'm in the emerge. I checked in endoscopy. The guy giving sedation in endoscopy, GP anesthesia, also does emerge. I said, George, I need you. He came straight to emerge. I only had to call in one extra doctor from outside because just by using my console, my dashboard, I was able to mobilize about 20 doctors to be in that emergency department within 20 minutes. And we had a real command center going. We had a doc in triage, greeting the ambulances. We had waiting rooms set up for families, for patients. It went super smoothly. And I sat there in shock thinking, oh my God, what would I have done before Pedal? Prior to Pedal, we had a lot of challenges with our scheduling, and we had been through a couple of, like Peter says, the low cost versions out there, and had significant challenges. Part of the challenges we had is that because we're a regional hospital, we rely a lot on primary care. So we have a lot of family physicians that wear multiple hats. So there's family physicians doing emerge, doing hospitalists, doing obstetrics, doing anesthesia, doing community work, doing palliative care. So their schedules are all intermingled. It's not like you have 6 cardiologists and they do cardiology and that's it. It's very rare in our area to have a person that does one thing. So it's extremely complicated, and waiting on one person to do a schedule to then do the next one to then do the next one had a domino effect that could drag on and on and on, and it resulted in us getting call schedules out at the very last minute. The other struggle we had is last minute changes. So as you can imagine, with a paper-based system or even a very basic electronic system, a last minute change can be missed. In fact, we have had it in the past where the wrong person was being called and patient incidents did occur because we just couldn't figure out who was on call. Sharing these lists, where do we deliver them to? There's an administrative assistant who's walking around half the day updating paper lists in all the departments. A doctor makes a last minute change. They're calling reception, they're calling east, they're calling north, they're calling all over the place to update them. This eliminates that. The other thing that we were able to get advantage of is seeing the whole picture, seeing the coverage of the entire hospital. So you might be on the surgical ward and you might be seeing the surgical call schedule, but it doesn't tell you who's in radiology. It doesn't tell you who's in emerge. It doesn't tell you who's in the ambulatory clinics. So by having the console, we get to have the big picture of who's in the hospital at any one time. And I've even used it to my own benefit. As I walk through a department or through AmCare, I'll see, oh, who's working today? And I'll go, oh, I haven't seen them in a while. I'm going to go schmooze. And then they think I'm so smart for knowing they were working that day. But really, I'm just using Pedal for my own social skills. Physician coordinates. So that's the other huge advantage that we found was solved by having this online system, is that people's phone numbers change. They change constantly. It's very hard to keep track of. My administrative assistant was constantly updating lists everywhere. Another real example, I got a text from a doctor just 2 weeks ago, and he said, oh, hi, Julie, just want to let you know I changed my cell phone number. And I went, okay, what do we do? And I went into Pedal. He had already done it. It's like, oh, yes, I'm so proud of my team. So it was seamless. And then this winter, I wanted to go to a cottage nearby. I was on call for hospitalists, so not the end of the world. I can be within 30 minutes. Plus, I'm the boss, so who's going to get me in trouble? So I went to the cottage for the night, and all I did was I went into Pedal, put in the phone number for the cottage, and I knew that they were going to be able to find me for that evening, and then the next morning I deleted it. So super easy. And then finally, the roles of the chiefs. I know we all have hospitals with department chiefs, and they have all sorts of jobs they're supposed to be taking care of. They have a role description that is bigger than the amount of time and funding allotted to them. So in the past, whenever I was trying to bring on a new chief, they would say to me, well, Julie, what is it I'm supposed to do? And I'd say, well, basically, you make the call schedule. That's your job. Well, not anymore, because this has eliminated so much of that work that really, when they say to me, well, what am I supposed to do? I'm like, well, you're going to be dealing with performance. You're going to be dealing with complaints. You're going to be looking at quality improvement. You're going to be looking at how can we make our department run better. And so the focus has completely changed for these chiefs from being the guy that makes the schedule to being the guy or the girl that is making the department work better. So for us right now, we're very pleased with the service that we have. We have schedules that are centralized in the dashboard. We no longer have to look all over the place for information. It's accurate, it's completely live and up to date. It's accessible on the mobile, and we're very, very reliant on our mobiles at this point. Little perk is that a lot of the hospital physicians are also community physicians. So as a family doctor in the community, if I'm sitting in my office and I see something that needs attention or a question to, let's say, a gynecologist. So I'm in the office and I have someone with a missed abortion. I don't need to call reception and figure out who's on call for gynae today. I pull it right up. I see it's Dr. Paquette. I call her right away. I say, hey, Steph, I have a question. Problem solved. It used to take an hour, 2 hours to have that problem solved in the past. And then the on-call lists are automatically generated from the physician schedules. It's so much easier to match the complicated, complex world we live in right now. And the reality of a small rural hospital is not only that we have doctors wearing many hats, but we also have doctors that work in many locations. So we're matching our schedule with Cornwall's, with Montfauve's, with TOH. So we have all sorts of blending and merging of schedules that has to occur. And this has certainly made it way easier. So I'm happy to take any questions and give you guys the real lowdown on how it works for us in a small Ontario hospital. So the question was about implementation and change management. At the time, we did have some struggles. I think getting people used to their mobile phones, particularly some of the older physicians, was a learning curve. They're all used to it now. We did have some issues with who's updating what info in the system, and we worked those out with Pedal MD because there was some blockage as to, they want, well, my secretary will fix that. Well, the secretary wasn't allowed to fix that, right? So we've had some issues with that all got sorted. I would say at this point, we're maybe 2 or 3 years out. There's been not a peep It's been completely integrated into the culture, and there haven't been any issues. The secure messaging, I'd say, is slow to pick up. We're not used to that, but we did recently have an online chat go on because we had a patient that was video recording us in Emerge, and it caused a lot of distress to the doctors, so they all started chit-chatting about that within on the secure messaging. So it's right now I can say it's really good. At the time, though, I will say that when we did have some questions and concerns, Petal did come out and did webinars with us, came to our Medical Staff Association meetings, did some education. So the support level from the company has been really ideal. Mm-hmm. Excellent questions. So the first one was who's managing the platform and who's putting in the schedules. And the second question is about funding. So for the first question, initially we had, as chief of staff, I had 2 administrative assistants. I had one dealing with credentialing and blah, blah, blah. And then I had another one that was really solely working on schedules and assisting the chiefs working on the schedules. By using Petal, what we were able to do is whittle down the amount of time that the administrative assistant was doing that, and really whittle down the time that the chiefs had to do that, such that that one main administrative assistant was able to take over the job, because it's really not a lot to ask of her. So I was able to actually reduce the resources required at the hospital for me. In the end, we ended up using her for something else. So it's not like we fired anybody. We used her for patient experience and to be a liaison with outside offices. But it did streamline certainly the amount of extra work that I had. But yes, so my administrative assistant is the manager and liaises regularly with Petal MD. As far as the funding, so yes, the hospital paid for this. The physicians are paying nothing. I think there's some mixed models out there. But being, once again, a rural hospital where retention and recruitment is a huge issue, this was one of the perks that we could offer to try and bring in doctors. So we put it into our hospital budget. I mean, otherwise we're spending money on recruitment and retention. So this is one way we looked at it. And now when I interview new doctors to come to Hawkesbury and I tell them, oh, we're on Petal, I often get things like, oh, that's great. Yes, I use them at so-and-so and I use them over here. So it has become a positive tool that helps us with the recruitment. So I'm not going to share the names of the other solutions that we tried. And adoption is 100%. 140 doctors, it's not like we're the Ottawa Hospital with 2,000 doctors. So it is a little bit of a manageable size where we do know each other face to face. There's not a single doctor that I don't know to say hi to. So we have been able to get 100%. And the family health team being already on an EMR means they're fairly tech savvy. We actually go live in 4 days with Epic. So the whole hospital is, it's getting there. But yeah, we have a really good bunch of doctors, and the buy-in is the advantage to themselves, right? So they see how easy it is for them. They see, oh, am I on call or not? They just look at their phone. So it's a no-brainer. That one's not hard. For the secure messaging, yeah. So I think it's a younger generation thing. It's the texting. What I'd like to see is there's still a lot of texting going on, and sometimes with patient information in it. So, privacy officers block your ears, but that's reality. So what I'd like to see is this more and more encouraged and less of the texting. And it's easy. I've used it myself from the phone. It's super easy. So it's just a question of shifting that culture and getting people used to it. And, the more the privacy officer crunches down on us, the more we're going to learn our lessons, right? So the ones that got caught, they learn their lesson. Mm-hmm. Yes. So when you're using the scheduling software, yes, you can create your own business rules and you can edit them as you go along. But what's fun with it is because it's so visible and everybody sees what everybody's doing, it's easy to trade shifts and it's easy to offer to the marketplace. So we actually did have an incident a couple of weeks ago where one of the Emerge docs got into a big fight with the radiologist. because the radiologist was refusing to do the scan, and then it became a whole personal thing. So then that emerge doc saw in 2 weeks, it's that radiologist on call again. He traded his shift, right? So it's so easy to be able to manage that when you see the big picture. And I don't care if he trades his shift with somebody else and somebody else takes it, fine. They're grown-ups, they can work it out. But so that was a nice little advantage. You can look ahead and plan. Mm-hmm.